is actually a critical part of our multidisciplinary head neck team. So she'll be discussing the swallowing rehab and for head neck cancer patients. Carol.
Hi, Dr. Zen. Thank you so much for inviting me. Hopefully my screen is showing appropriately.
It looks good.
Okay, thanks. So just going to quickly hope to hit on a couple of important objectives. So really the importance of having speech therapy be incorporated before, during, and after any treatments, whether it be adjunctive or surgical, to review some evidence-based exercise programs, and then look at some outcomes with speech intervention. So obviously we know that, as Dr. Zen just shared with us, the tissue toxicities that are going to impact the motion of the larynx and the pharyngeal musculature. So our ultimate goal is always to reduce the risk of aspiration as a result of glottal incompetence, and obviously we don't want to have any pneumonias. We know that the conventional wisdom for people, because of pain and loss of taste and loss of saliva, is that they tend to eat less and eat less dense or heavy food consistencies. So we know that disuse atrophy of the muscles involved in deglutition occurs because we don't have that resistive load of heavier foods. People immediately get rid of meats and breads in their diet, and so aren't challenging their muscles the whole time through because it's painful and more difficult. So we're trying to always avoid that disuse atrophy, but try to maintain a safe swallow as we go along with the patient. So usual care for patients in head and neck clinic basically begins at the multidisciplinary tumor board, when the team discusses what will be the most effective intervention for this patient. And when it is determined that they are going to be receiving chemoradiation, our speech pathology team and nutrition team jump into action, get the patient scheduled for a pre-education session before they even start. And we do some of these self-rated tools like the EAT-10, the VHI-10, the performance status scale for head and neck cancer, just to kind of get a baseline of where the patient feels they are. We always do a clinical dysphagia eval, so a look, listen, feel with different PO textures and volumes to see what is going to be the safest. And we're hoping that the patients don't have some pre-existing dysphagia, but we'll talk about that. Then we provide them a notebook of handouts related to focusing on high protein foods, focusing on high water content foods, foods to avoid, really getting on board with aggressive oral hygiene right away, making sure they're brushing their tongue, trying to keep their taste buds really moist and clean. And then focusing on eating more frequent meals, maybe smaller meals more frequently, and using some nutritional supplements. We also always endorse stretching exercises to try to avoid that trismus and some of the fibrosis that we know can occur. Then we schedule sessions with both the speech pathologist and the dietitian out of about week 4 of radiation, and then every 2 weeks after that, depending on the dysphagia severity that the patient's experiencing. When we notice that there is a pre-existing dysphagia, especially if it's more than just a mild dysphagia and a patient is having signs and symptoms of potentially penetration or aspiration, in other words, that wet vocal quality, throat clearing, coughing with PO intake, having to do multiple swallows to get a small volume of food down, we may recommend an instrumental swallow exam. And the gold standard is still the modified barium swallow study that you see on the left side of your screen, which is done in radiology under fluoroscopy. But we can also do a fiber optic endoscopic exam of the swallow in the clinic with the surgeons and the physicians, and just add blue dye to the food and watch what's happening, whether they're having early loss into the larynx and pharyngeal area, if they are aspirating before or after the swallow. The only problem with the fees is that we miss that moment of the swallow itself, but we can see what's happening before and after. And obviously our goals are always to avoid aspiration and try to maintain the patient being able to eat the safest diet for as long as possible. So sometimes that means diet modification. And I have here just an example of the newest vernacular for speaking about dysphagia diets. And this is the based on the International Dysphagia Diet Standardization Initiative, which went into place about 3 years ago. And all hospital and skilled nursing facilities are required to start adapting this at this point. So you'll see in the liquid triangle at the bottom, instead of saying nectar thick or honey thick, we are now saying mildly thick or moderately thick. And instead of just saying mechanical soft in the food diet triangle, we're saying minced and moist or soft and bite-sized. So that allows us to have the same vernacular, be talking about the same diet as patients transfer and move through the continuum of care. In terms of compensatory strategies, speech and swallowing specialists, will always have a bunch of tools in their tool belt, such as chin tuck, maybe teaching a breath hold, trying head turns potentially to the side that's impacted, using alternating liquids and solids or double swallows to try to, again, get the food through the pharynx as effectively and safely as possible. So the age-old question that always comes up, the ongoing challenge, who should be getting these PEG tubes? So a study at MD Anderson really identified and highlighted about 5 big risk factors, and Dr. Zen mentioned a couple of them, but we need to be very mindful of these level or T3 and higher stage tumors that those patients more than likely will need additional nutrition support for longer periods of time. Anybody who has a pre-treatment dysphagia during that initial evaluation, more than a mild level, should be watched very closely, because we know that people's swallow function declines and we anticipate that it's going to get worse. People who report very severe pain with swallowing, people who are actively smoking, and anyone who has already had a baseline weight loss of potentially 10% body weight should be considered for a PEG. The research also supports for patients who got PEG versus those who did not during chemoradiation, a lot of really impactful changes. So lots more mucositis in people without PEGs. 41% had interruption of treatment in order to allow them to get the PEG during treatment. And again, a significant weight loss in patients without PEGs. So if we see those 5 key factors in the education consultation, we will talk to the surgeon and the radiation oncologist about considering a prophylactic PEG. The goal, though, is to keep people swallowing. And so the use it or lose it mantra comes into play. Again, the evidence base tells us that patients who continue to eat PO or exercise their swallowing muscles fare better than those who do not. And patients who both eat and exercise have the highest return to a general diet and the shortest PEG tube dependence. So given that, we really were searching for a protocol at our clinic to really implement an exercise and eating program for our patients. We looked to the MD Anderson speech pathology program, and they had a program called Pharyngicize, which this sort of highlights some of the exercises and activities that were introduced to their patients. So we also, from their research, we found that 91% of patients going through radiation treatments who are aspirating, who are known to aspirate from an instrumental exam, have very low maximum expiratory pressures. for their respiratory volume. So we wrote a grant and implemented expiratory muscle strength training protocol with a bastardized version of the pharyngeal size, which we now call swallow size. So we offer patients who are willing to go above and beyond the usual care to use one of these EMSTs, these exercise or expiratory muscle strength trainers, for the whole time they are in radiation therapy. And the idea is that it's the rule of 5. They select 5 days out of the week and do 5 puffs against resistance into that EMST in sets of 5. And they do it 5 times a day. So 25 reps, 5 days a week. And then every week they turn the resistance up 1 level. So they're getting, maximizing their respiratory support and then advancing it to try to make it a little bit harder for them every week during radiation. Those who are likely, what we know from the research, people who use this EMST are 2 times more likely to end up on a general diet or that regular texture diet than those who did not. In addition, our swallow size exercises really look at maximizing the laryngeal excursion and the base of tongue pressure strengthening to affect that most efficient swallow. So we have them do sets of 10 of these exercises 4 times a day in addition. So they're exercising a lot in addition to eating a regular or whatever diet we determine to be the safest. So I thought it would be interesting to look at 2 sort of similar patients. Both were T2 tonsillar cancers. You'll see that one of the patients was 70, one was 56, both received the same amount of XRT. One patient, the 56-year-old, did 2 cycles of chemo but couldn't tolerate the 3rd. So also the 56-year-old had at baseline in the pre-radiation evaluation a mild oral dysphagia. So we're already seeing that this patient had some dysphagia going into this. So again, just to review some of those self-rated tools, the EAT-10, the PSS-HN, you can see that both patients, both the 70-year-old and the 56-year-old, had some increase in symptoms on their EAT-10, but both kind of after radiation therapy went down to almost baseline measures. Really anything above a 3 on that tool indicates that there's some swallowing concern. Their PSS scores basically were both back to normal. But look at the difference in the patient, the 70-year-old who agreed to participate in the EMST and swallow size program versus the 56-year-old who did not. He just did not want to participate in it. So he ended up having a break in his radiation therapy and had to get a PEG because he had lost so much weight and was basically unable to swallow anything except a few sips of water about week 4. So both, reported pain and loss of taste sensation, but it improved pretty rapidly, especially in the patient that was able to keep swallowing and keep eating, the 70-year-old. So what about these patients who have persistent dysphagia after radiation and chemotherapy? So, the University of Florida actually about 10 years ago piloted a new program for chronic dysphagia, and it's called the McNeil Dysphagia Therapy Program. McNeil was actually a patient of Dr. Crary and Carnaby who had significant head and neck cancer and had gone through radiation and chemotherapy and was NPO and PEG tube dependent. And they just thought, we've got to do something for this patient. So they looked at the exercise physiology literature. And if any of you are familiar with the Lee Silverman voice therapy program for Parkinson's disease, they used kind of a combination of those programs to develop this really intensive rehabilitative program. It's a 15-session, 1-hour session program that uses increasing load, repetition, and frequency to try to improve just and expedite a most normal swallow physiology. And so there's a food hierarchy, and what we're doing is we're starting with people. We do a modified barium swallow study to decide what is the safest diet, and then increase the amount of food. So from a teaspoon to a soup spoon to a tablespoon of let's say that pureed kind of food texture, and then we go up to the minced and moist, and then we go up to the soft, and eventually they are able to take normal sized bites of normal texture foods or general texture foods. And again, with the same thing with liquids, we start with 5 ml or a teaspoon of liquids and move up until we can achieve a normal swallow, hopefully in those 15 sessions. And the goal is really to get that person to swallow 80 bites, 80 to 100 bites or sips during the hour-long session. So it's been fairly effective. I've used it now with 4 of our head and neck patients who had chronic dysphagia after XRT, and most of them have been able to advance to a almost normal diet. Maybe not the starches and really tough meat, but most of them have been able to eat almost everything that they want. So what are the take-home nuggets? Of course, I'm going to advocate for involving a swallowing specialist or a speech pathologist and a dietitian as soon as the intervention plans are recommended. And obviously, this goes for our surgical patients too, but for the purposes of this study, we're talking about the before radiation and chemotherapy begin. Really be aware and mindful of those key factors that are going to put somebody at higher risk for needing long-term or I guess short-term enteral support. Anything greater than a stage 2, people who have pre-treatment dysphagia, and those who are still smoking. And then be super encouraging of patients to continue to eat whatever they can that has been determined to be safe, and keep exercising their swallow muscles throughout their treatment. Even if they're really not taking anything other than just maybe some water or Gatorade, keep having them, encouraging them to do the exercise plan and the EMST if they've opted to do that. Here's the references, and thank you very, very much. Appreciate being able to share.
Thank you very much, Carol. We have a few questions for you later.
Okay.
So our next speaker is Dr. Brandon Coutu.